right, so today we are joined by Dr. Jason E. Portnof, DMD, MD. All right, so today we are joined by Dr. Jason E. Portnof, DMD, MD, FACS, and he's kind of a big deal. He's an oral surgeon in Boca Raton. He's got a super handsome picture on his website, by the way, with glasses. Are those fake or real glasses? Because I don't remember you. They're
Yeah,
real? Okay.
as
Because
I
I don't
get
remember.
older, I need them more, you know?
True. I was going to say, I don't remember you in dental school needing glasses, but I thought you just wore them to make you look more distinguished. But um,
That's the beard. The
that's the
beard
beard.
does that,
Yeah.
yeah.
Yeah. I also want for my website to get a picture of me, like in a suit with my uh, chin resting on my fist. I think that makes you look more distinguished too. Um, so, Dr. Portnof is a diplomat of the American Board of Oral and Maxillofacial Surgery and a fellow of the American College of Surgeons. His interests include long walks on the beach. No, that's not right. Um, he's got a full scope of oral and maxillofacial surgery with an emphasis on the correction of dental facial deformities and corrective jaw surgery, maxillofacial reconstructive surgery, and corrective jaw surgery for TMJ and orthognathic surgery, oral and maxillofacial pathology, and complex dental implantology. Dr. Portnof graduated with honors from Nova Southeastern University in Fort Lauderdale. I know because I was there with him, so I can confirm this. Um, he also earned an MD from Weill Cornell Medical College in New York City, where he was trained in oral maxillofacial surgery, and he received a fellowship and training in pediatric maxillofacial surgery and craniomaxillofacial surgery at Royal Children's Hospital in Melbourne, Australia. He has written many peer-reviewed articles and presented both nationally and internationally. He's also held numerous teaching positions at prestigious universities, including Albert Einstein College of Medicine, the Weill Cornell Medical College, and Florida Atlantic University, and our alma mater, Nova Southeastern University. It would take me forever to read all of his education and training and affiliations and appointments and clinical specialties. So let's get right down to it. How you doing, buddy?
Doing good, man. Of all that stuff, my biggest achievement is being your roommate. That's my I forgot what year it was, third or fourth year, I think, but that was the best part about all that training right there.
That was a good time. That was a blast. We had a lot of fun. Actually, Porty and I, excuse me, Dr. Portnof, we also could have filmed a mockumentary when we did the Florida boards together back in 2002.
Absolutely.
So after we graduated, I absolutely felt no sense of relief because we had to drive up to Gainesville and check into hotels for 5 days so we could train for the Florida boards. And if you remember, it was like Team Gordy versus Team Becker.
That's right.
Yeah, we were Team Gordy. So Dr. Gordy was like the legend. He was like the Florida board whisperer. And I think we paid him like, I don't know, maybe like
Yeah,
$8,000.
$1 million, whatever it was.
Yeah. But Dr. Gordy and I think Eyelid Dental were the only winners there. But and I remember at the first class, which was actually at Nova with Dr. Gordy, and there was another dentist he was probably in his 50s or 60s, and he took the Florida boards, but he let it expire. And then he decided to go down and retire. So he was there taking the course with us. So I told myself, even though I'm here in Massachusetts, I'm going to pay that every 2 years, I'm going to pay that license fee
Absolutely.
forever. We worked so hard to get it.
Yeah.
But yeah, that was that board is crazy. Do they still do? So they have it at Nova now, right? It's in
Now they have
Gainesville
it.
and Nova.
I mean, it was a whole production when we took it because it was only offered up in Gainesville. We had to drive up there, and we were, the recent grads from the newest school in Florida, and we were convinced that they were going to be, prejudiced against us because we were the Nova, team, the Nova contingency. So we were doing everything we could to blend in and kind of make ourselves seem like we were, Florida, UF graduates. But it was crazy stressful, and that's how dentistry began for us, just being a whole ball of stress. And like, there you go, and you start off stressful, and does it get any easier? I have no idea. Throw in a pandemic or two, and we're not any less stressed for it.
Yeah, it was outrageous. I mean, the amount of stress during that week of the boards, like you said, it was up in Gainesville, and it was like, Nova versus UF, students, like we were like the outsiders coming onto their turf and, taking their exam. But it was crazy. You'd hear whispers in the elevator of where we're training, and someone would be like, you got to get the red stripe burr, the diamond, the fine diamond. If you're not, you're going to fail. So we'd all run down to Island Dental and buy the red striped, crown prep burr.
I'm pretty sure
Uh,
Island Dental like started those rumors. You know what I mean? Like whatever they
yeah,
were in full stock of. We got a whole bunch of these red diamond burrs. Somebody let out the secret that you need those red diamond burrs to
yeah,
graduate.
they leaked the information. They were laughing all the way to the bank. But I guess, and I don't know how it is now in Florida, but if it's still the way it is, but I understand that they made the exam so difficult to try to keep out, outside dentists that just wanted to retire there and not make it oversaturated. But I mean, we had to buy patients. We had to buy human beings.
Correct.
So I remember mine actually turned out to be the same patient. So I had the same patient for the class 2 amalgam and the scaling and root planning quadrant. And I think I paid $1,000 for each. I didn't get a discount or anything for having the same patient, of course. Um, but I'm not sure if it's all mannequin these days, but I literally did the tiniest little incipient lesion on this guy.
Sure.
Meanwhile, he had rampant caries,
Yeah.
and
Of course.
I did
Yeah.
this tiny little amalgam on him, and he probably had gross periodontal issues too. But I picked the quadrant that just had the 5 millimeter pockets.
Right.
Um,
But this is
and
not ethically sound for sure. This this whole process.
it was all about money. I mean, that guy's probably, do you think the Florida boards, kept in touch with him to see if he was continuing on with his
Yeah.
dental treatment?
There's no follow up there. And I also heard stories about people that would bring their own patients in, and right before they walked in the door, they would turn around and say to the dentist, hey, I'm not going in unless you give me another $500 right now, cash. And then we run into the cash machine. Like I'm on a timer here. I got to get in there before the go. And they got to get cash before they, they'll sit in the chair. So it's crazy.
Yeah, we really should have filmed a mockumentary about it.
Yeah.
But yeah, a lot of our stress started there. So how long have you had your practice in Boca Raton?
Well, so after I finished my training, I did a couple years of academics in New York, and I moved down to Florida. And I was actually full-time faculty at Nova for about 7 years. And then 2 years ago, I opened up my own office in Boca Raton, Surgical Arts of Boca Raton, right at West Boca Medical Center. It's been a project, of passion and love and sweat and tears and everything. And I opened it up right before the pandemic started, about a year beforehand. So, just enough time to get some momentum, and then, hit this big barrier, so, everybody kind of felt the same kind of stress at that point. This is unprecedented times for anybody. So, that was surely a wake up call for a lot of people. In dentistry, in medicine, there's no real official class about business, and there's certainly no class in any school about how to deal with a pandemic, but you're kind of learning as you go, and it takes, from what I understand, a good 5 years to get things oiled and the machine rolling, so that you could really just kind of let things, the systems work themselves. And 1 year was certainly not long enough before when I was not prepared for like a pandemic, a world crisis like this, but nobody was. So we just gotta kind of roll with it, and take it as it goes.
Yeah, it's hard enough to start your own practice, and
Yeah.
get, like you said, get the momentum going and build it up, especially when you base a lot of your business off of referrals, and
Right.
then all of a sudden the world stops for 3 months. How long were you actually shut down for?
So that my practice is a little bit unique. So I take call at about 6 different hospitals. So that actually helped me keep things going during the pandemic. I really didn't really shut down at all because for the first week while we were trying to figure out what was going on, a week or two or so. But because I'm on call at all these hospitals, I was taking hospital call, and what they were doing is they were diverting the patients to my office, right? So a patient that would come to the ER for dental pain, a mandible fracture, facial trauma, something like that, rather than admitting them to the hospital, they would actually, siphon them off to my office, and I would be prepared to handle them on an emergency basis. So, I kept the lights on in my office. I was able to take care of the population, for their needs, and keep them away from the hospitals where the COVID patients were going, and keeping the beds open in the hospitals, for those patients. So it actually worked out in my favor. So before that time, and everybody was like, "You're crazy. What are you doing taking call at 6 hospitals?" And I'm gonna run around, driving here and there, 24 hours, every day, 7 days a week working. And then when the pandemic hit, it actually was a little bit of a cushion for me. So not many people have that type of practice, and I wouldn't say it's not something you can sustain. You know what I mean? Like, it was just so happened that I was fortunate to have that kind of arrangement going. But that's not a long-term solution for a private practice by any means.
So you already had affiliations with these hospitals before COVID?
Yeah. So while I was working at Nova, I had hospital affiliations. I was taking call with residents, and then I expanded. I started taking call in other hospitals. Right before I was leaving Nova and building my own practice. So I was taking call at Broward Medical Center, Memorial Regional, Joe DiMaggio Children's Hospital, and then in Palm Beach I was at Delray Medical Center, West Boca Medical Center, Boca Regional Hospital, and so I was taking a bunch of hospital call, throughout a couple counties, basically. So that was, I like to do that type of surgery, facial trauma, reconstruction, things like that. So, that's my interest, and that kind of helped me during that time, and also kept me doing the work that I like to do.
So when you say take call, is this a situation? A patient shows up to the hospital, has facial trauma, and you're like the go-to person. They call you, and then you're basically beeped. It could be in the middle of the night, and then
Yeah.
you're expected to show up. Are a lot of these like car accidents, or
Yeah.
what's your?
Car accidents, interpersonal violence, people beating each other up, dental infections, things like that. So we get a lot of down here also a lot of elderly, so there might be some falls, people trip and fall, or have a syncopal episode or something like that. So facial trauma is pretty, it's always, there's always a flow of that, into the ERs. And then, the oral surgeons will be on rotation, sometimes in combination with plastic surgeons that do facial trauma coverage. And they'll call us, you're on 1 week, you're off another week, and they'll call you whenever you're on, you know.
You're also in South Florida, which is probably one of the craziest places in the world.
Yeah. I'll say, yeah,
Because there's
spring break time, we always have a little bump in the facial trauma, when people, start to get drunk and beat each other up.
Yeah, well, you have that. Then you have a lot of the elderly. I think you're also just some people are just batshit crazy down there. But then you're also dealing with the aesthetics. You probably have a big population that is really into cosmetics and aesthetics, and they want that OM1 shade of a smile in their teeth to match that golden brown tan.
Yep.
So you got a combination of all that going on.
Yeah,
So how do you?
I was gonna say that makes the dental implant, practice kind of, a little bit more, the patient's a little bit more critiquing.
Yeah.
They got a certain cosmetic mindedness to them. So.
Yeah, so you probably have, case selection and tempering expectations is got to be a big part of what you do. And there's some patients that you just say, this is not a good fit, and
Yeah, at first I would see every patient. I'm here for you guys. Let me, feed them all in. Bring them all in, and let me see if I can help everybody. And then, as you realize, some people may have a little, expectations are a little bit unrealistic, and maybe they're not. No matter who sees them, nobody's going to be able to, give them exactly what they want. I need this now right away, and they're just not a candidate for that, So, sometimes it's education, educating the patient of what is possible and what, we can offer them, and sometimes, if they're unwilling to see it, let them see a few people before they kind of come to realization that, their expectations are, unattainable, you know. So,
Okay, so like for me, I'm a GP, so if I have a case that I don't feel comfortable, I refer them down to Boca, down to you.
right.
But you're like the end of the line. So as an oral surgeon, specialist with all of your training, do you just tell the patient that, this here's my treatment, these are the expectations? Do you just tell some patients straight out that I don't feel comfortable treating you
Well,
because of the
yeah, I mean, so look, I do a lot of my prosthetic work that I do in combination with the restorative dentist, the prosthodontist, general dentist, and these are conversations we sometimes have to have together with the patient. You can do a combined consult. My office is big enough. I have I think five chairs that are all my office, all my rooms are you can do dentistry or surgery in, and I have five rooms that a dentist can come and we can talk to the patient together. I do combination cases where I have two ORs, and I'll do a surgery where I'll let's say extract teeth, bone graft, and the restorative dentist will be there to temporize while the patient's asleep. And so we do a lot of work together. And sometimes even the consults. They have the restorative dentist has to be there, giving them expectations, what they can do. I can put implants in bone, but it will be, able to be restored. Prosthetically, can it, will it look right? You know what I mean? So now with virtual planning and 3D printing and things like that, we can really show a patient what they're going to get, beforehand, and which is great because then it kind of cuts down on, oh, we can do all this for you, and what the patient thinks and what you can actually produce is different. So it's better to be able to show them virtually or even with a tangible model what we can actually do. And we do a lot of guided surgery. I haven't placed an implant very rarely without a surgical guide, and I'm usually doing that in combination with the prosthetic or restorative dentist. So we do a lot of communication. That's the key. Communicating with the dentist, communicating with the patient. Everybody's got to be on the same page.
Yeah, I think that's so important. So how do you split your time now? Are you like 50/50 private practice and teaching or affiliations at the hospitals?
So now I'm really all private practice, right? But I take call at the hospitals. Two of the hospitals that I take call at, I have residents, oral surgery residents. I do some teaching. I do some courses at Nova. I do the AAID course. So I'm basically, I also teach at some of the med schools. So I'm kind of, I'm mostly private practice, but I definitely keep my hands, in education. I like it a lot. So, I try to, publish a paper a year. If I miss a year, I try to do two the next year. So, I still work with the residents on working on projects and things like that. So, I kind of keep my hands in it, but right now I'm fully private practice.
Okay, so I'm going over some of the procedures that you do in your private practice, and I get, dental implants, wisdom teeth removal, impacted canines, oral pathology, bone grafting. Can you explain orthognathic surgery and corrective jaw surgery, and some of the other procedures you do, like facial trauma, TMJ disorders, and pre-prosthetic surgery?
Yeah, absolutely. So we'll start with orthognathics. That's jaw surgery. So a patient that might have a underbite or an overbite that is skeletal in nature. So it's not something that can be corrected with orthodontics alone, right? So the orthodontist maybe has tried in the past to put the teeth together, but there's just a discrepancy between the upper and lower jaw that's too big. It could be a centimeter or more, and basically the problems within the skeleton, not within the teeth. So what we do is we do orthodontics in preparation for jaw surgery. That's actually not the same orthodontics that you would do for, just cosmetic orthodontics. This is, we're actually making the bite worse before we do the surgery, so we can get the best bang for our buck in the jaw surgery. And then we might move the lower jaw forward, the upper jaw forward, back, whatever it is, to get the teeth together, so they're optimized and chewing and functioning properly. And you get a lot of cosmetic advantages to that, because as you correct the foundation, the skeleton, the soft tissue drape over it, often improves, the outcome. The profile gets better. The patient becomes more pleased with their, facial features. So that's usually, it's a combination. You start with orthodontics, we do the surgery, then there's post-op orthodontics. It's a full, treatment course. So that's something we do. As part of the cleft and craniofacial team at both Joe DiMaggio Children's Hospital and Miami Children's, now Nicholas Children's. Basically, some patients have congenital facial deformities, and we work on those patients. Improving their bite, improving their appearance, things like that.
So you see, you do this on both kids and adults.
Yeah, I mean, you generally want to do the orthognathic surgery on a patient that's completed their growth. But there might be some other things for a craniofacial patient, like a patient with cleft palate, cleft alveolus. Maybe we have to do some bone grafting, or something like that, in preparation for orthodontics, prior to jaw surgery. So as they grow, they have different needs. We address those things as they grow at different stages in their life.
Okay. And okay, so this facial trauma, TMJ disorders, are you like kind of grandfathered in now? There's a new pain specialty in dentistry.
Well, we work with those specialists. So I have general dentists that maybe down in South Florida, we're treating TMJ, and they have practice just for TMJ and facial pain. They've been doing this for years. And they might have been grandfathered in. I'm not quite sure to that specialty, but at a certain point, certain patients may not get better with conservative treatment, right? And they tried splint therapy and muscle relaxants, anti-inflammatories, things like that, physical therapy. It doesn't work, and they still have a problem. Usually, depending on MRI images, we'll figure out whether or not there's a problem in the joint that can be addressed surgically, and whether it's arthrocentesis or arthroscopic surgery or something like that, or even beyond open joint procedures. There might be a solution that we can offer them surgically. I'm pretty selective in the patients that I treat for these things. We try to avoid surgery when possible. Sometimes doing surgery can open up a like a Pandora's box, and kind of like be the beginning of a a downward spiral, and eventually they might need some sort of joint replacement or something like that. But if the patient can't get better with conservative treatment, then there are surgical options sometimes that can help them.
Do you do joint replacement?
I have done joint replacements. Yeah, so we do. Sometimes we do custom joints with a company called TMJ Concepts. These are pretty extensive surgeries that a patient has had multiple procedures in the past that failed, and then now their only option is prosthetic joint. There's options before that, obviously, that we try. We try to do the most conservative first, and then if there's nothing else left, then the joint replacement is the answer.
Yeah, this year I've made more night guards than any other year because everyone is so stressed out.
Yeah, for sure.
Everyone's grinding their teeth. So facial cosmetics. Can you do anything about this double chin here? Is that part of your repertoire?
Just, 5K a day. I think that'll take care of that.
I'll just grow a beard like you have, and
that's my trick right here. Yeah. But I do some minor cosmetic things. Do Botox. We do some Restylane. Do some implants, not dental implants, facial implants. Some patients need a genioplasty, which is could be a cut in the bone, moving the chin forward, plates and screws to hold it there. I have colleagues that I work with that will do, eyelid procedures. I don't do those, facelifts, things like that, neck lifts, but those are not things that I kind of do.
That's actually a big thing in Korea. My wife's Korean, and getting eyelid surgery in Korea is like a common thing.
Yeah.
Just a fun fact there. for you. So like, what's your bread and butter? Is it implants and wisdom teeth? Does that take up most of your time?
Yeah, dental alveolar wisdom teeth. I mean, that's kind of like the staple. And even during the pandemic, some patients would have an infected wisdom tooth that needed to come out. Dental implants, not so much. You can't really sell anyone for a this is an emergency medically necessary dental implant. But I'd say during the lockdown, wisdom teeth that were infected or symptomatic, sometimes would be we would do them. But yeah, I would say the bread and butter is extractions, and sometimes bone grafting, preparation for implant, treatment, so and wisdom teeth for sure.
What implant system do you use, or do you usually go with what the referring dentist wants, or
Yeah, I
how does
mean,
that
most
work?
of the time, it will go with what the referring dentist wants. I have, in my office, I use Nobel and Zimmer mostly, but if a dentist has a preference for a different system, I'll use whatever they request.
Also, what about coronectomies? Is that becoming more popular now, whereas a third molar that's close to the nerve?
Yeah, for sure. I do those a lot, and with cone beam CT scans, right, we can see where the tooth is in relationship to nerve much clearer than we used to. So where something maybe would have been all right, let's take that tooth out. Now we can see it so distinctly and in three dimensions. So more patients either are screened and you can see that they definitely or a coronectomy would be indicated, or something that might have been confusing and let's just do a coronectomy. But actually, when you look at it on a 3D scan, you can see that the nerve is far away. But I definitely, I mean, I do them all the time. They're sometimes I'll get a patient that's older with longer roots. I mean, more often now than before, and I'm not quite sure if it's now everybody's got some sort of insurance and they're coming in, and maybe they didn't have insurance when they were 16, but they have it when they're 35 or 40. And so as you're seeing more older patients, I think a lot of these patients, a coronectomy might be indicated just because the roots are longer and closer to the nerve. So definitely it's a valuable procedure, and I do it often for sure.
Do you pretty much take a CBCT on all of your implant and third molar cases?
I do them for implants for sure. The third molar cases, I do it when it's indicated. If it looks like it's something on the Panorex that I got a question about. There's another side of cone beam CT scanning, which is basically you're giving them more radiation. So you gotta really weigh the pros and cons because it's not completely benign. The radiation is cumulative. You give it to them. Some people I know will scan somebody every few months or whatever. I mean, that's a lot of radiation. It's hard to justify that. So in the right patient, I do a scan, but I don't do it for everybody. The image you get is by far superior. I mean, like you see things you couldn't see on a Panorex. But is it worth the extra radiation dose? I'm not sure if it's that all the time.
Yeah, I do. I take a CBCT on every implant case too, because
Yeah,
I mean, it's the more information you have, the less stress that it
absolutely.
gives you, the quicker the procedure, the more efficient. I 3D print a guide on every case too.
Yep.
And I specifically got, it's now Cavo Curve, but it used to be called Gendex. It's a 6x8 field, so it's a small field of view. So, for someone like an oral surgery office, it wouldn't be a large enough field of view. But for what I'm doing with just implants, it's a small enough field of view where there's not as much radiation. But I would never go back to freehanding
No,
implants. Now that we have,
yeah.
you know,
It's hard to justify it. And as far as I have a big field. I have or 17 or whatever. I got the big field ICAT. And one thing I do is when I get a scan, I get it read by a radiologist, right? So not everybody does that. I do it. I think it's I'm an oral surgeon. I might miss something. You know what I mean? Like I've been reading these a long time, but let's say we do a full scan and there's an osteoma in the skull and I don't see it, you know what I mean? Or calcified pineal gland and I don't look at it, you know what I mean? Like I'm really focused on the teeth and jaws and there's something that I can if I can send it to a radiologist and then talk with the patient about it. Hey, look, this was seen by the radiologist. Maybe you need to get it checked out. Calcifications in the carotid, so, something that might have a health impact on them. I think it's a great screening tool. If I'm getting the big field anyway, I send it to a radiologist. I send it to beam readers. Actually, just point of information. I sent it to mostly Dr. Arasso, who used to be our head of radiology at Nova. He works at beam readers in, so I sent him to him, and we got a good communication going. If he sees something, sometimes he'll email me. You know what I mean? Like, it's a good. So not only do I have a radiologist, but I have somebody I can actually have a conversation with if there's something concerning.
Yeah, that's such a smart idea with that field of view. I mean, you're covering yourself,
Mm-hmm.
you're giving your patient, information that they need, and it probably helps you sleep at night. If you didn't take it and someone else did later on, well, how come you didn't pick this up and you're liable? So I think that's really smart. So what about anesthesia? How does that work in your office when you have someone? Do you do general anesthesia, or is it IV sedation, or do you use both?
Yeah, I use both. So, I used to be actually an inspector for the Board of Dentistry for anesthesia. So I would go to the offices that were applying for an anesthesia permit, and we'd have guidelines that the office had to meet, and we check it off. And if they were up to snuff, then we would sign them off. Now it's different. This past year, they have full-time employees of the Department of Health that is doing it. But anyway, I set my office up because I had already had the knowledge of what to look for in an office. So I set mine up to the guidelines. I have two big operating rooms that I can do general anesthesia in. I do anesthesia myself, or I'll bring in a CRNA, a nurse anesthetist to do the sedation for me in a bigger case, right? So if it's just wisdom teeth and it's something, it's going to be 30, 45 minutes or so. I generally tend to be a little bit conservative with my sedations. I keep my patients pretty light, and it does. I think it serves me fine. I haven't had any issues. Knock on wood. I sedate the patient. They're comfortable. Using midazolam, propofol, ketamine sometimes, fentanyl, sometimes. But I tend to do a lighter sedation for my patients. They don't remember anything because of the midazolam. They're comfortable. Their recovery is quick, and they go home. If it's a long case, like a multiple implant case, something like full arches or something like that, I'll bring in a certified nurse anesthetist to do the sedation while I'm working, because I like to focus on the surgery and not have to think about is my bag of fluid running out, if the guy is the guy's blood pressure going up. Those are things that I'd rather have some help with, so I can focus on the surgery. But I do believe in the single surgeon anesthetist model. I think it works when appropriate. On certain cases, I think it's better to bring in some help. In my office, I have everyone in my office is ACLS certified, and I did ACLS, PALS, and we actually brought a guy in named Rick Ritt, who does a course on mannequins in my office, so we can do emergency training. Our office staff is highly trained for these things. We run, quarterly drills to make sure everybody's kind of on their toes and everything like that. So anesthesia is something I take pretty seriously. And we're also right on the hospital campus. God forbid something went wrong, we have our backup right there. And then there are some patients that are not candidates for office anesthesia, and those patients I bring to the hospital. So the whole anesthesia starts basically on the preoperative assessment. Whether or not you feel like that patient is somebody that could go to sleep in your office safely, or if you got to go to the hospital and have a medical anesthesiologist put them to sleep while you do your surgery under general anesthesia. So, it's really about, making the right decisions, preoperatively, I think.
So I imagine kids, the elderly, obese, immunocompromised, those types of patients, those are the ones that
They're going to the hospital. So, I'll sedate some kids really young. Nope, I'm going to bring them to the hospital. You have to really be an ASA 1.5, like maybe, one or two. Yeah, but if you're a 3, 4, you're not going to sleep in my office. I had one lady, I remember she was pregnant, history of diabetes, all this stuff coming in. She goes, "Am I going to sleep?" I'm like, "I don't know. Are you tired? Because you're not going to sleep by any sort of sedation here, But if you want to take a nap, feel free, So, I think it's choosing the right patient to go to sleep in your office, and the wrong ones need to go to the hospital in the hospital setting. Yeah, sometimes I'll do a local anesthesia case in the hospital setting when a patient is super sick. You know what I mean? Like, even the anesthesiologists there don't want to put them to sleep. They just want to be monitored, So, we'll get some, variations of health, what I mean, coming into the office, So
Is there a feeling of kind of comfort and safety and security when you're doing a case in the hospital?
yeah, I mean, anything can go wrong, but at least you are in the setting where everybody is trained to react. I mean, from the nurses to to the staff, everybody is on the same page. I mean, like, you don't want to have an emergency in your office ever, but I think hospitals, they have emergencies daily. You know what I mean? So it's kind
Hmm.
of like, I definitely think that if you're gonna have a sick patient that needs oral surgery work, doing them in the hospital setting, is probably safest, when those patients need to have it done,
Now, are you able to compartmentalize if something does go wrong? I mean, there's 99.999% chance that, with me as a GP, that patient's walking out of that chair. Then maybe they're leaving
Yeah.
with one less tooth,
Right.
but they're walking out of that chair. And I've had a lot of patients that, I've had implants fail, or I couldn't save their tooth and they're crying. We've had some, minor emergencies, but um, what about yourself as a surgeon, especially in facial or trauma cases? Um, how does that work mentally for you if something, always knowing in the back of your mind, something could go wrong?
Right. Well, I've been called for some facial trauma on, let's say, a motor vehicle accident patient that had a lot of body trauma, and they called us in when the patient was first admitted to the hospital. They're bleeding profusely from their mouth. They also have they're unstable. Broken ribs, flail chest, internal, abdominal organ damage. So we got called by the trauma team to stop the bleeding in the mouth. So we go in there, blood's everywhere. We're just trying to temporize. Throw a wire around some broken jaw, try to tighten it and stop the bleeding from the bone in there. Use some bone wax or something to stop bleeding. But in the end, that patient, getting transfused while we're working. I mean, the patient, actually, the one I'm thinking about in particular, didn't make it. We actually ended up, performing CPR on this patient, in the OR. I mean, and they didn't make it. So I mean, it wasn't from the jaw injury, but they're just overall they're not a stable, healthy patient. So and it doesn't happen often, but and when it happens, it's a unique kind of stressful event. And for sure, people talk about it, and the providers, sometimes you have to kind of lean on each other to kind of take that in, but I during my training, I did 6 years of oral surgery training, including med school, and then additional year in the hospital, in at the kids hospital. You can see some things that are pretty distressful, it's you never get used to it, but it's definitely part of the training, and kind of accepting it as your part of your growing and your growth as a doctor and healthcare provider. So and I think now the trainees that have been in training during COVID, it's been a unique experience that nobody could prepare for. So yeah, I think this is a different time of training, and a lot of stress that hasn't been around since like the turn of the century. So
Yeah, and I imagine the ERI doctors, or cardiovascular surgeons, or anyone that is trying to save someone's life. You have to be able to accept the fact that not everyone is going to survive. Um, there are a lot of sleepless nights sometimes in your line of work. Are you better now mentally with it than you were earlier on in your career?
yeah, I mean, there's sometimes, look, sometimes there'll be a certain patient that you think about, and keeps you up at night. Something didn't quite go the way you wanted it to, or they didn't heal right, or it's a tough clinical course, something like that, and that could wake you up at night. And taking call, sometimes I wake up in the middle of the night. Did I miss a call? I check my phone. You know what I mean? Like, as I'm older, I think I'm sleeping a little bit more heavy, what I mean, than I used to. And, I worry that I missed a phone call or something like that, but, overall, I think it's, I think taking call to hospitals is something that you do often in the beginning of your career. And as you get older, you kind of phase it out, so, at a certain point, I'll probably, try to hand it over to the younger surgeons, and take my step back, what I mean? But right now, I'm still feeling I can do it. So, I kind of keep it going, but how I feel in the future.
So I want to ask you a few questions about just dentistry in general. What would you say is your favorite part about going to work every day, and what's your least favorite part?
So I like what I do. So I go to work. I'm happy about doing dentistry and oral surgery. There's sometimes I'm stressed about a certain patient, or let's say it's a difficult procedure I'm about to do. Sometimes I'll think of that. That'll be stressful or something like that. But one of the things that I feel is the most stressful is I like to you want to keep your patients happy. You want to provide them with a service, and you want to, give them what they want. I think sometimes, as we talked about before, sometimes patients' expectations are a little bit out there. And now with the internet, and how quickly people will write a review about you, that is sometimes stressful. Like, I find that a patient that has a mediocre or bad experience will be quick to write a review. First thing they do before they leave your office, will be, being online on Google, or whatever it is, and but somebody who you bend over backwards and provide them with the best care, and they have a great outcome, they just might expect it. You know what I mean? And no little note about you online. They just kind of go through their day. So I find that most of the time the bad reviews are related to payment, right? They, a patient will, think that they have insurance and that should cover everything. And, what do you mean the cone beam CT scan wasn't covered by insurance? I pay for my insurance. Yeah, I understand you pay for your insurance, but your insurance doesn't cover cone beam CT scanning. And unfortunately, what you have requires a cone beam CT scan, as the best treatment option for you. You know what I mean? So, and then my fees are not extraordinary, right? So, I find my fees are pretty reasonable, even lower than a lot of people in my community. But this is crazy. I can't believe they're expecting money for this. They write something online, and a lot of times, if you click on the patient's review and you see what else they've reviewed, they'll review, McDonald's, KFC, Walmart, and I'm like, great. I'm glad I'm lumped in with all these, kind of, like chain, fast food restaurants. What I offer you is not fast food. I mean, I'm trying to, I think of myself, I went through all this training, I'm trying to give you the best possible care out there, top technology, top experience, and, if you think of me as a Big Mac, I don't know if I could ever really, give you what you want, so those are things that, it's pet peeves, I know a lot of dentists and, oral surgeons kind of complain to each other about that, but
Hmm.
it's we're not fast food. We're trying to provide a top notch service. And it's the science behind it is decades, and we're way more advanced than back in the day, where pull this tooth, no way to replace it with a dental implant, bone grafting. I mean, geez, we have PRP, PRF. I mean, there's such science behind what we do. I mean? I think patients don't realize that sometimes. They just think that, they're going to the dentist like they're going to get their hair cut. You know what I mean? Like, just the expectations are different than what our expectations are.
Yeah. Also, with in a general office like myself, I see these patients many times a year, and I have relationships with them. I see their families, whereas you may have a lot of patients where you only see them once,
Correct.
so you haven't really built up that rapport yet with them. And you're right. A lot of times, or most times, a bad review is something non-clinical. It's because of insurance, or I had a patient call me an a-hole, and threatened to write a bad review because I dismissed her because she had refused X-rays for like 4 years and um, started this Facebook battle.
So
Yeah, so it's just reviews are they're a blessing and a curse in the profession sometimes. But I'm gonna ask you one last question. Um, what you know now, what if you could go back and change something that you did or didn't do, what would it be in the dental profession?
we when we were in dental school, they offered a master's of business administration combined with our program, and I think a couple of guys signed up for it. I remember Randy and Daryl, I think, were the two guys in the class that did it. I don't even know if they finished it, but we probably should have done that. I mean, because jumping into this, with no education about, I mean, we studied, you know, class two preps. We studied dentistry, daily every day. But running a business is a whole other ball game. And I think that would have really been beneficial to get that baseline knowledge in dental school, where you just get the theories behind it. Uh, you know, um, dealing with insurance companies, things that are just, you're thrust into this as a business owner, but really without any, they're at the advantage because they've been doing, this is their business is their life. Here we are, we're clinicians, and now we're trying to dabble in business. But I think that had we done that, maybe we would have had a little bit of a background and a little bit more savvy once we opened our own practices. We learn by trial and error, and I found there's a lot of learning. There's a big learning curve. So there's a lot of mistakes that we made in the business aspect of it that I think we could have maybe avoided had we got a little background in that. That's what
That's,
I would do.
yeah, so true. I mean, we come out and we're one of the rare professions where we can have a very successful business without any business background whatsoever.
Right.
And they don't teach you any of that in school or about dealing with staff, insurance, any of that. And in your line of work, you're also dependent on referrals. So that's a major part of your business.
Yeah.
Um,
Absolutely.
yeah. So, all right. Well, let's wrap this baby up. Thanks so much, Dr. Portnof, oral surgeon in Boca Raton. How do patients or referring doctors get in touch with you?
So my website, Surgical Arts Boca Raton. I think we have an email. It's info@surgicalartsofbocaraton.com. And we're happy to see everybody. And any questions anybody's got, clinical or otherwise, I'm happy to answer them. So appreciate it. Thanks for your time. Thanks for inviting me here. It's been great to catch up with you. We got to do this more often. Maybe not on the recording, but just in general.
Sounds awesome. Yeah. Thanks for joining us.
All right, man. Thank you.
All right. We'll be in touch.
Sounds good.